Okay, we're live.
All right. Hey, everyone. Welcome back to another edition of Tumor Talk. We got the gang's all here today, which is great. As everyone knows, this is a collaborative effort between the Journal of Neuro-Oncology, Lenox Hill Neurosurgery, and the tumor section, where we highlight recent publications in the journal. And today we're super excited to have Michael Zhang, who did work with Gordon Lee out of Stanford. And Michael, why don't you introduce yourself and tell us a little bit about what you're going to talk about today and give us some background and some data.
Yeah, thank you. Thank you all for inviting us. My name is Michael Zhang. I'm a fifth-year neurosurgery resident at Stanford. During my research period, I've been mostly interested in neuro-oncology, and so I worked with Dr. Gordon Lee, and today we'll be talking a little bit about this project that we focused on immune-related adverse events, particularly in the setting of non-small cell lung cancer, metastasis to the brain, and looking at how these affected outcomes. Should I get started? I'm happy to get started. If that's okay with you?
Yeah, absolutely. Don't be offended if we chime in with comments and questions either, okay?
Please. I welcome
Pretty
it.
informal.
So as you can see from the title, we're going to be looking at the outcomes for patients who are treated on pembrolizumab and they experienced immune-related adverse events in the setting of non-small cell lung cancer, mets to the brain. For the people who may be less familiar with checkpoint inhibitors, this is just a very brief background. But checkpoint signals exist normally in the body because of the need to suppress inflammatory reactions that may be undesirable when the body doesn't require it. However, for tumors, they can also express the ligand that binds the receptor, leading to a suppressive event that can actually protect tumors from being eliminated. And therefore, as one tool in our armamentarium in immunotherapies, we've developed checkpoint inhibitors. And these antibodies, they can block that interaction between the tumor cell and usually a T cell to then recreate that inflammatory response. And so you can see here in this little figure here, there are a couple pathways, a couple checkpoint inhibitors that we have developed already in clinical implementation, including those targeting CTLA4, as well as the PD-1 pathway. So both targeting the PD-1 receptor as well as the PD-L1 ligand. Going to the non-small cell lung cancer population, a couple of these agents have been approved. And you can see here the whole list. Mostly they fall under the category anti-PD-1 and anti-PD-L1 inhibitors. And you can see here the timeline at which they were approved. And you can see that they're mostly recent, most of them in the last 5 years. The first one was nivolumab, I think in 2015 as a salvage monotherapy. But the more recent ones are here boldened. Pembrolizumab in 2017 was a first-line monotherapy for those with tumors expressing PD-L1 with greater than 50%. Nivolumab got first-line approval as a combination therapy, actually with ipilimumab, which is one of the anti-CTLA4 inhibitors in platinum therapy. That was just in the last year. And then even more recently was atezolizumab, which is another first-line monotherapy approved for those with high-expressing tumors. Durvalumab is another option, but that's as a continuation monotherapy and more for locally advanced diseases rather than specifically brain mets. And even before all this, there was a lot of interest in targeted therapies and still ongoing interest in targeted therapies for patients who have EGFR, ALK, and ROS mutations in their tumors. And in the context of checkpoint inhibitors, patients are given checkpoint inhibitors as a third line if they have a known targeted therapy, because they're usually going to be receiving platinum chemotherapy as a second line agent. So that's the landscape for a patient who has non-small cell lung cancer with brain mets. Usually they have to go through one of these treatment arms. And again, our project focused on immune-related adverse events, which are basically one of the specific side effects that patients experience with immunotherapies. These are basically, they can affect any organ and are a result of an antigen response to the immunotherapy. They can affect a large proportion, and in this meta-analysis, they showed that for anti-PD-1, PD-L1 therapies, about 26% of them among the entire tumor population experienced some form of an adverse event, but some severe ones, about 6%. And those are graded on a 1 to 4 scale, with 3 and 4 being those who have a need to maybe discontinue therapy, or for those who may need a hospitalization because it's so severe.
Michael, can you give, we have our audience is pretty broad. There are a lot of neurosurgeons, neurologists, neuro-oncologists who listen, but there's also students and patients who listen in because we're easily accessible. What are some of these more severe grade adverse events? I mean, I remember in the paper itself, you mentioned that people could even be hospitalized for some of these. What do they entail?
Right, right. Thank you. Again, they affect all the organ systems, so it depends on the organ. For example, with the skin, you can have Stevens-Johnson's disease, where you're basically, having a severe large area affected by the treatment. For the GI system, you may have severe diarrhea, multiple events that are controlled by steroids and are also just leading to constitutional decline. Pneumonitis is usually very, very concerning. Endocrinologically, you can have pituitary disorders that require replacement. And for the CNS, certainly there's like encephalitis, which in case you would most definitely require some stopping and hospitalization for that as well.
Yeah, so they're pretty broad in nature, what could happen to you. I mean, the stuff listed down below where it says, most commonly affected, it says skin reactions, that anything with high cell turnover, right? Where you would expect there to be effects, your GI tract and then your skin. But then also you could get these encephalitides, or you could get, pituitary dysfunction, like you mentioned, hormonal discrepancies. Yeah, it's pretty broad. Interesting.
Right. And
all right, sorry to interrupt.
No problem. And it's probably worth mentioning, though, that there are those grade 1 and 2s, which are not so severe, and they can be, very minor. It can be just a certain rash. It can be, just a little bit of dyspnea, a couple instances of diarrhea. So it doesn't necessarily have to be as dramatic as the grade 3 and 4s that I'm mentioning, but those are the ones that you certainly want to be mindful of as you're following a patient through their treatment course and seeing if they're going to be continuing on a therapy, or you need to consider an alternative.
Yeah, I think that's a huge point, right? You're saying 94% of people aren't affected this badly, right? That's a very small percent of people who do get this. So,
and as you can see here in the next section, there's a lot of variation, again, just on the type of agent that people are getting. So we've mentioned the anti-CTLA-4 treatments, the anti-PD-1s and anti-PD-L1s. They're known to be higher for ipilimumab, the anti-CTLA-4, which is a cited event rates of 42%. It's also noted to be higher for combination therapies, which again include the ipilimumab. So unsurprisingly, also high, 59% in one study. And but for the anti-PD-1, PD-L1 therapies, they're a little bit more tolerated. And you can see here they're under 10%. Again, I mentioned there's also variations by the sites at which they are affected, and also the type of pathology that's being treated. So for non-small cell lung cancer, the most common locations I mentioned were skin, pneumonitis, and diarrhea. There's also variations in when they may occur. So some of them happen a little bit more aggressively sooner. And so ipilimumab, within 2 weeks, most of them were experiencing their side effects at that point, and 5 weeks for anti-PD-1 therapies. And so part of the proposed mechanism is that, again, there's an antigen response that may have an overlap with the primary pathology, in which case, if there is this antigen response, the patient can theoretically benefit from experiencing an IRAE. So the skin, which is very similar to non-small cell lung cancer, may therefore generate a protective inflammatory response once they've experienced that adverse event. However, being antigenically affected may not necessarily result in a strong T cell response, and therefore you may have a severe reaction, say, for example, in the brain with the encephalitis, but you may not get that benefit that you would see in the skin. And so a lot of studies have been done showing that IRAEs can be beneficial in the non-small cell lung population. And here you can see a study among people with rashes, most of them being low grade. There was better responses in terms of time to treatment failure. And you can also see that patients who are immunologically predisposed, as measured by this study where they showed those with responses to IRAEs, they actually had a higher baseline level of antithyroid antibodies in existence. So again, just a multitude of studies showing benefit in the non-small cell lung population, as well as other cancer studies looking at IRAE impacts. And you can see here this large Italian group studying over 2,000 patients saw with nivolumab monotherapy benefits in overall survival, as well as time to treatment failure. This group that showed the antibody response also showed objective response rates and progression-free survival with IRAEs. And then this large European study with over 30 institutions also showed that with PD-1 treatment, they were able to show response rates, progression-free survival, overall survival for various grades, for various types of side effects, whether or not they started or discontinued therapy. So this brought us to our study, which is specifically focusing on brain mets. And so I think our community knows that patients who experience brain metastasis for various oncological disorders are with worse prognosis. However, it's very hard to study them because many of the guidelines and randomized trials that are used to make recommendations do not study specifically patients with brain metastasis, and making it even further harder to study that association between IRAEs and brain metastasis for these treatments. So here's a couple other references where this group, they actually did in a phase 2 trial, specifically looking at those with non-small cell brain metastasis. They show that the survival is lower, but again, they're not focusing on the IRAEs. And then in this one major study, only about 20% were with brain metastasis, but the survival is much higher there. So this leads us to our study, where we decided to look at our institution experience with pembrolizumab, one of the anti-PD-1 inhibitors. We identified 63 patients who were started on pembrolizumab at the time of diagnosis of brain mets or after that. We gave them at least 6 months, we made sure they were at least followed for 6 weeks to ensure treatment effect, as well as followed for at least 6 months from the time of diagnosis of brain mets. We looked at various features from their molecular status regarding PD-L1 expression levels, molecular characteristics if they had EGFR, ALK, ROS1 mutations, and then also how they were treated. So how many treatments they had before diagnosis, after diagnosis, which ones were they, surgery, radiation. And for our outcome variables, we were most interested in seeing if we can identify improved time to treatment failure or overall survival. And time to treatment failure was specifically looking at follow-up imaging, whether it be systemic or brain MRI, systemic CT scans or brain MRI, and that would have to have shown consistent progression or from the oncologist's perspective, a need to change regimen. And so from the 63, 24 patients were with IRAEs, and you can see here some of the pertinent variables that we identified from a cohort, mainly showing that between these two groups, their molecular statuses were comparable. So they had similar EGFR mutation rates, similar amount were with PD-L1 expression levels in the tumor, and there were a comparable amount receiving pembrolizumab as a first-line agent or a targeted therapy as a first-line agent. And this is particularly important because for patients who have targeted therapies, there is a known understanding that they may not respond as well to checkpoint inhibitors such as pembrolizumab. And therefore, it's important to kind of control for this to make sure that they aren't just the ones who are having poor performances and bringing down the overall means for comparisons. Here we do show that the patients who did have pembrolizumab-related IREs, they were with a slightly higher rate of surgery for primary control. There was a trend towards a higher rate there. And this goes back to your question about what kind of reactions they're experiencing. And so in our cohort, some of them did have multiple IREs, but here's the distribution, most of them being skin, lung, and GI, consistent with what I was describing before. Most of them were low grades, and a good proportion did experience still high grades. And this is our primary outcome here. You can see here for the entire cohort of 63 patients, 24 with immune-related adverse events, there was an improvement, at least statistically shown, for overall survival, systemic time to treatment failure, and intracranial time to treatment failure, as evidenced by the survival curves and the p-values here. Overall survival was 21 months compared to 10. Systemic treatment failure 15 to 4, and brain 14 to 5. And then from there, we decided to stratify our cohort to make sure our findings were robust and consistent, focusing mostly on severity and molecular status. So you can see from the literature that a lot of people are interested in focusing on patients who have high expression of PD-L1 because for them, there's an expectation that the treatment should work or more likely to work. And for this group, there was again robust demonstration of improved outcomes for overall survival, systemic and intracranial time to treatment failure. When we looked at those who had lower expression levels, actually none of these outcomes were consistent, held. And so for the patients with PD-L1, we did not see any of these benefits. after having experienced an immune-related adverse event.
So that's less than 50% though, right? That's so that intermediate grade, that 1 to 50%, you're not seeing this result in those people. This is really high expression PD-L1 with an adverse event.
Right. So this slide is one with high expression levels, and these
with an adverse event though, right?
Yes.
Yeah. Even if it's a grade 1, any sort of event that suggests that you are being affected by your therapy.
Exactly. So having had the adverse event, having had a high expression level, any grade would have shown these outcomes for this cohort. But for the groups that had less expression and had any grade adverse event, there was no improved benefit seen.
I find this so interesting. I got to tell you, I mean, I hate to cut you off, but I mean, you're not looking at a modest increase here. You're looking at like a year survival difference with an adverse event, right? That's very impressive, you know. So I just find it a very impressive result. So yeah, keep going. Sorry to interrupt,
Michael, but you also have it looks like more IRAEs in those that have a higher PD-L1 expression. Is that right? So if we go back to your slide, you've got 24 and 39. Is that correct?
Yes, 24 and 39.
Yeah. So in the PD-L1 expression in the IRAEs was typically you had more patients with a greater than 58%. Yes. So I think that's another sort of telling thing, is that these may go hand in hand. In other words, the PD-L1 expression and the IRAEs.
Yeah,
that is possible. Yes. I will finish off with a couple more survival curves, and then I'm happy to go back and scrutinize these numbers again, because I do think that there's a lot of subtleties.
We only got a half hour. We can't be that nitpicky.
We also looked at severity of the IRAE. So looking at the patients who had high grades, so again, grade 3 and 4, these patients were also with consistent improvements, particularly for overall survival and systemic treatment, time to treatment failure. However, for intracranial time to treatment failure, this was not statistically different, although there was a strong trend in that direction. This is definitely with the caveat that our once we start substratifying, our cohorts are much smaller. When we look at the patients who had low severities, which may be biased again by the type of organs that are being affected now, you can see again the improvements in outcomes for all 3 of these categories as well. And then going back to the molecular status, our thoracic oncology team wanted to make sure that our results were robust for not just patients who were without targeted mutations. So we looked at patients who had EGFR versus those without EGFR. And we were able to show that there was at least some improvement for the systemic time to treatment failure, but the other ones were only with trends. And then finally, we just did a multivariate regression looking at overall survival. We did it for time to treatment failure as well, but for the purposes of this talk, I have here just a chart for overall survival. And you can see here that for patients who had IRAEs, this was an independent predictor. Other ones that were important variables were targeted therapy use as a first-line agent, extracranial disease control, and a number of lesions treated by radiosurgery. And so at least for these, it seems like this is consistent with our expectations. Potentially for use of targeted therapy as a first-line agent, that may be because the patients who ultimately get a checkpoint inhibitor therapy in our cohort were getting it as a salvage therapy. But at least for us, in these final comments, we here show that among patients treated with anti-PD-1 therapy in the non-small cell population, there's seemingly consistent improvements in overall survival, as well as systemic and intracranial disease control, specifically for patients with PD-L1 expression greater than 50%. It does not seem to be restricted to a certain severity category, and EGFR mutation didn't prevent them from seeing a benefit. Now, that being said, there's always additional personalization we can do in our care as we get more and more nitty gritty with the molecular status of these patients. And so that leads for a lot of follow-up questions in the future, especially when we develop the cohort sizes necessary to see the signals. And so some areas of interest are, for example, which is more indicative of an optimal outcome, PD-L1 level greater than 50%, whether or not they have a targetable mutation, whether or not they have that adverse event with or without one of these two situations. Certainly the combination of sequences is going to always be an important question, because if you look at these patients' charts, they're oftentimes getting 4 or 5 different therapies, whether they be targeted or immunotherapies, chemotherapies, and then certainly where radiation or surgery fall into place of those, how they may affect the abscopal effect. That all becomes an open-ended question here. And then another question is just, how does PD-L1 level become interpreted? Because right now, a lot of these PD-L1 levels are determined based on the primary pathology or the biopsy that's obtained from whatever site they were obtained, but not necessarily the brain, because not all of them are getting intracranial surgery. So is there concordance between the organ that we're interested in, as well as the organ that they're basing their decisions off of? As well as this new role of PD-L1 standing in tumor infiltrating immune cells. I recently learned that there is now indications for using anti-PD-1 therapy for patients who have, I think it's like greater than 10% of tumor infiltrating immune cells with PD-L1 levels. So that's now another population of cells that one must consider when looking at whether or not this treatment is indicated and how that affects IRE status. So that's the primary data that I have here to share with you. I want to thank the teams that were involved in the study. Certainly Stanford Neurosurgery, Adrian Rodriguez is a fantastic medical student I worked with, and Dr. Gordon Lee, my main mentor, the radiation oncology team and the thoracic oncology team as well. I'm happy to answer any questions I can about this and join in on the conversation with adverse events and immunotherapies.
Great job, Michael. Thanks so much for being a part of this, and give our regards, obviously, to Dr. Lee as well. I think it's a very, very cohesive, comprehensive study. I think you guys did a great job. One thing that I like to do is kind of put like a big summary on this. And so I guess how does this affect your clinical practice? Now, obviously, that I don't know how it affects your clinical practice necessarily, but have you spoken to Dr. Lee about how how he's using this information and what he's telling patients about it, or how he's using it clinically?
Yeah, I mean, I wish I had that seniority and experience to make a little bit more of a personal comment on that. But I know for Dr. Lee, this was something that was of interest to him a long time ago. Actually, he and I did another study related to IRAs and melanoma. So I think that it consistently has been a source of, I guess, optimism, where you have a lot of patients who deal with a lot of difficult side effects, but at the same time, he knows that for some of these patients, at least a significant amount, they are able to benefit at the end of the day after experiencing a bit of a setback from these IRAEs.
Well, Jason, we actually contributed or collaborated on a paper looking at time to immunotherapy after radiosurgery. And you mentioned it briefly towards the end of your talk, but this kind of synergistic effect that can occur. Now, in this case, I'm not sure, this is systemic cancer, obviously, we're looking at here. We're looking at PD-L1 levels that could be from a brain met or the systemic biopsy, right? And that's what you're talking about.
Right.
But I guess the question is that something to think about this, with regards to brain tumors in particular, looking at that synergy? Do you have any of the data in terms of timing of immunotherapy to radiosurgery?
Yeah,
Michael, I was asking.
Yeah, I was going to say, Michael, I'll just interject and say, and then I'll let you take over, Michael. But I think that this is a fascinating study. One, you've got a lot of potential opportunities to augment this response, and I agree with you. This is not something that one necessarily hopes to see in patients, but in reality, it's likely the whistle on the train to something that's going to prove to be more meaningful, either ways that we can predict a more optimal response to immunotherapy and these targeted approaches we're doing for not only brain metastasis, but systemic therapy. And then are there ways that we can accentuate this response in a controlled fashion? So I think, but to Randy's point, we do see that close proximity of radiosurgery, typically followed by immunotherapy, appears to have some synergistic effect. There's an upregulation of apoptotic genes. There's going to be some degree of inflammation that's primed by the radiation in advance of the immunotherapy. And I have had some patients who have developed these IRAEs, and we haven't looked at it as systematically as you have. But I think it's in a place such as yours, great place, Stanford, you probably have some very meaningful data where you could look at the timing of radiation in relationship to some of these IRAEs, and what that may help to predict. But
Yeah, absolutely.
Michael, what are your thoughts?
I agree that this is the timing of it, specifically the radiation, is really fascinating. And just in response to your comment about your experience with radiosurgery before immunotherapy, I was recently reviewing vaccine therapies and noticing how for them, radiation after vaccine administrations, for cancer vaccines, that was actually immunosuppressive. And so it makes me wonder, like, is it only one way that you can really get that beneficial response? Do you need to do the radiation before the immunotherapy? And I apologize, I don't know the literature for specifically that timeline. But perhaps then you can trigger the beneficial response if you do the radiation ahead of time. Or I wonder if you could do it for, try to elicit a small low-grade IRAE, such as a skin reaction, that would benefit more systematically for the patient, because that would be ideal if you can avoid, the severe IRAEs in order to get that overall benefit.
Yeah, and to your point, I mean, there are ways that we augment vaccine trials, tetanus toxoid, GM, CSF, other sorts of things that may be used to prime dendritic cells and other sorts of things that may elicit a immune targeted vaccine type trial. So there may be ways to augment this too.
I think it's also worthwhile to note that the non-small cell lung community, as well as just any of the other primary cancer communities like melanoma and breast, they have been looking at this for a while now, and so they're kind of ahead of us in terms of learning about IRAEs and how they affect the body systematically. It's just because our cohort is such a limited population and harder to accumulate, and for studies, makes it harder for us to make those conclusions. But they're potentially already looking into these ways to augment that IRAE outcome benefit that we're hoping for.
Yeah, I would say it's likely to benefit both intracranial as well as extracranial responses. So it could be a win for them and for us, or for the patients we treat.
Absolutely. All right, everyone, we're approaching the 30-minute mark. Fascinating study, Michael. I really appreciate your time. This will get posted onto YouTube. Obviously, you can share with your family, friends, colleagues, and we'll see everyone. I think next week we might be off, but the week after that, we'll be back. All right.
Thank you.
Thank you, everyone. It was a pleasure.
Great work, Michael. Thank you.
Take care, everyone.
Good work, Mike. Take care, everyone.